This is Frances Russell, and in this module, we will review lung ultrasound scanning technique for identification of A-lines versus B-lines.
So to perform lung ultrasound, there's two different probes you can use. You can either use a C6 probe or a P4 probe. Both will allow deeper penetration, so you're able to evaluate the lung. So the lung zones are broken up into 4 in each hemithorax. So as you can see on the right side of the lung, zone 1 is medial and superior. Zone 2 is going to be medial and inferior. Zone 3 is up in the axilla, and zone 4 is going to be inferior and lateral, and the same thing on the left side. So your medial lung zones are divided by your parasternal line and your anterior axillary line. And your lateral lung zones are divided by your anterior axillary line and your posterior axillary line. And your superior zones from your inferior zones are divided by the anatomic nipple line. It'll be really important when evaluating your inferior zones 2 and 4 on each side that you are not getting the diaphragm or any bowel gas in view. So you want to start off in zone 1. You want to have the indicator, which is the knob on the side of the probe, up towards the patient's head. This will give you a view of rib with shadow, and then your pleural line. You want to make sure you also have a lot of depth. So you want to have anywhere from 16 to 18 centimeters in an adult. So this is a video example of how you would acquire the images on the right hemithorax. So when we're looking at the lung, we're actually looking at something called reverberation artifact. So if you remember from your physics lecture that the ultrasound is constantly sending sound waves out to image the body. So the ultrasound is sending multiple sound waves. Some of those sound waves go down, they hit the parietal and visceral pleura, and they bounce back up to the probe. That's going to give you your pleural line. Some of those sound waves, however, take longer to return back to the probe because they're bouncing between the visceral and parietal pleura. And because the ultrasound automatically thinks everything travels at the same speed, it's going to think that it's further away. So it's going to give you a horizontal line further down on your ultrasound monitor. And that'll continue, so on and so forth. So essentially, you'll have pleural line in these recurrent horizontal lines. These are known as A-lines. So again, we have our pleural line. Here we can see rib with shadowing, and then we have these horizontal A-lines that are occurring at equal distances. You see this in patients with normal lung. You can also see this in patients with asthma and COPD. B-lines, on the other hand, are going to erase A-lines, so we no longer see those horizontal lines that we could see in the last image. B-lines are going to extend off the pleural line, go all the way to the bottom of the ultrasound screen. They're going to move as the patient's breathing in and out, and you may see 2 or less in a patient with normal lungs. Once you start to see 3 or more, that becomes pathologic. This is an example of a patient with interstitial edema. So you can see those B-lines are moving as the patient's breathing in and out. Again, they're extending off the pleural line and they're extending all the way to the bottom of the ultrasound screen. And if you see this in 2 out of the 4 lung zones bilaterally, then that patient has interstitial edema or pulmonary edema, and I would be concerned for heart failure in that patient. So other things that can cause diffuse B-lines outside of heart failure include non-cardiogenic pulmonary edema. So if that patient had renal failure and fluid overload, if the patient had ARDS, pulmonary fibrosis, or a diffuse pneumonia or pneumonitis. If you saw B-lines focally, you'd be concerned for a focal pneumonia, a pulmonary infarct, a contusion in the setting of trauma, or even lung cancer. So again, just to compare and contrast, A lines on the left, you see these horizontal lines extending down, versus B lines on the right. You can see as the patient's breathing, they're coming in and out of view. There's more than 2 of them, and they erase A lines. This is just another video example of a patient with multiple B lines, and you can see they have so many B lines that they're starting to coalesce together.